usually jaundice appear later. Why? It is connected with process. First, affected liver cells, cytolysis hepatocytes, and first time appear intoxication syndrome because disturbed basic function of the liver, what is disintoxication. But to develop in jaundice must be affected 70% of hepatocytes. And maybe patient, younger men, children had good regeneration process, good vascularization. And this day, hepatocytes affected, but next day, appear new hepatocytes, compensatory function very good, and don't develop in jaundice. But when patients older, adults and older patients, bad vascularization system, poor regeneration process, and usually developing jaundice. But necessary time. First time, don't affected 70% of liver cells. And usually characterized first time pre-ecteric period and after developing ecteric period. It is common because clinical picture of all viral hepatitis, of all etiology, common. Specific changes, for example, viral hepatitis A, when appeared jaundice, you're now virus eliminated and decreased intoxication syndrome. But it is characterized mild and moderate course of disease. Severe cause, you understand, continue intoxication syndrome. Incubation period specific for each viruses. Incubation period, yes. It is connected with etiologic characteristic each virus. But liver cell, all viruses affected hepatocytes.
So in this way, we can directly link some groups hepatitis.
Doctors, when patient has clinical picture acute viral hepatitis, what is clinical picture? Intoxication syndrome and jaundice. But thank you. You don't know what is etiology of disease. Before laboratory diagnostics, you then don't may say what is the diagnosis. You maybe only think. For example, patient had contact with viral hepatitis A patients. For example, this child from primary school were registered children with viral hepatitis A. You only say it is epidemiological contact, but necessary control because present laboratory test. Epidemiological service don't take information from you if you say only epidemiological contact. No, please come in. Necessary confirm laboratory test. And for example, wife infected viral hepatitis B, husband infected 1 week ago, yes, and hospitalized in our clinic. But it's maybe not viral hepatitis, maybe viral hepatitis A, yes, necessary effective laboratory test.
It's like we go to all test or normal.
No, confirmed diagnosis, don't on the gammogram, confirmed ELISA analysis. You must detect markers and detect genetic material, which is RNA or DNA or viruses. Doctors, please remember, 2 groups analysis. First analysis is characterized patient condition. What is it? It is chemogram, biochemical test, level ALT and AST characterized. What is a marked cytolysis? Mild, moderate, or severe. For example, cytolysis, ALT and AST 500, mild coronary disease. Yes, when 1,000, moderate. When 4,000. You understand? Total hepatocytes affected, severe coronary disease, but connected with clinical picture. For example, mild cause, absent intoxication syndrome, only patient feel anorexia, low decrease of appetite and weakness. When patient has vomiting, it is moderate cause. Multiple comorbidity, disturbance of sleep, it is severe consequences and connected with a level of ILT and IST. But you understand only patient's condition and diagnosed acute viral hepatitis. Maybe. You now will be discussed the bacterial hepatitis. But it is characterized severity of disease. But etiology of disease, you must detect it, infection agent or immune response against infection agent. What is antibodies? You must detect it himself, infection agent or antibodies. And to the confirmed diagnosis viral hepatitis, you must detect it, markers. Okay. What is?
It becomes chronic
Doctors, please, it's information you must discuss with your teacher. Wednesday, I said for you full information. Online doctors waiting us. Please continue, discuss next viral hepatitis. Sorry. 33 doctors waiting us. And doctors, next viral hepatitis delta. This delta virus detected delta antigen 1977 year. Scientist Rosetta detected delta antigen from hepatitis B virus patient. This patient had outcome cirrhosis. And first time science Rosetta thinks if maybe next fourth antigen of hepatitis B virus. But after examination studied, detected another genetic material. It is RNA virus. And it is defective virus. This virus don't have cover, absent superficial antigen. And delta virus take HBs antigen, superficial antigen of B virus, and take from hepatitis B virus, defective. And you understand, if absent cover, virus take cover from hepatitis B virus, patient may be infected virus hepatitis delta when present virus B. Necessary HBs antigen. Viral hepatitis delta is a viral hepatitis with a contact mechanism of transmission of a pathogen caused by a defective virus. The replication of which is possible only if the body has HBs antigen. And doctors, please look electron microscopic photo HBs delta virus, and where it's a microscopic photo, and this is the structure RNA virus, where delta antigen RNA, virus hepatitis B DNA, and cover from B virus HBs antigen. Don't you understand? Virus, why necessary HBs antigen to virus B? To presentate it on hepatocytes, connected with proteolytic albumins of the wall of the hepatocyte. And if absent HBs antigen, virus don't make presented on the hepatocyte. And the hepatitis delta virus presented to hepatocytes from HBs antigen. If absent HBs antigen, human infected delta virus, but virus don't present it to liver cells and don't develop an infection process. And two forms of viral hepatitis B. What is acute and chronic, and registered two variants delta virus. And please look structure hepatitis delta virus, where RNA virus covered, RNA of virus covered of HBs antigen. And large and moderate, large, moderate, and small HBs antigen particles. This consists cover of virus. And etiology of hepatitis delta virus. Hepatitis delta virus belongs to the genus delta virus. It is spherical particle with diameter of 35-37 nanometer. The hepatitis delta virus outer shell is formed by the surface antigen of hepatitis B virus, HBs antigen. And the genome consists of a ring minus RNA chain. And 8 genotypes have been identified worldwide by a comparative phylogenetic analysis. And each genotype has geographic area. Please look. Genotype first is the most frequent and has variable pathogenicity. And genotype first registered in the world, in all continents, in all countries. And genotypes third, second, and fourth are found in East Asia, causing relatively mild disease, And genotype third is found in South America and associated with severe course of the disease. And genotypes 5, 6, 7, and 8 have been found only in Africa. And doctors, when you detected what is genotypes of our patient, you understand what will be prognosis. For example, if genotype second, usually prognosis satisfactory. Very good, satisfactory. But when you detect the genotype third, you understand patient will be had severe course of a disease. And doctors, from all viral hepatitis, delta viral hepatitis characterize severe course of a disease. It is connected with pathogenesis. We'll now discuss. And please look, virus hepatitis delta resistant in environment, resistant to ultraviolet rays, heat resistant, destroyed by formaldehyde and activated by alkaline. And epidemiology, doctors, who is source of infection? Human, yes? And usually what is human? With chronic forms of it and acute forms of viral hepatitis B. The source of infection are persons with chronic forms of hepatitis B virus infection with a delta IgG. And hepatitis delta virus transmission mechanism, parenteral. And it is mechanism common for viral hepatitis B. And usually prevalent artificial ways. What is? Injection, hemodialysis, hemotransfusion. Doctors, persons with chronic hepatitis B virus infection in the world reduces how many? 2 billion. And from 2 billion people, 5% infected delta virus. And patients with chronic viral hepatitis B group risk to infected delta virus. Why? Because in the bloodstream of this chronic hepatitis B virus patient persisted HBs antigen. It's HBs antigen necessary for delta virus. And who is group risk? Humans who have multiple sexual contacts, it is prostitutes group, and humans who have multiple injections, it is drug-induced persons, and humans who have hemodialysis and hemotransfusions, it is persons with kidney disease and hemodialysis, and hemotransfusion, it is another disease, for example, after catastrophe, and doctors have severe course of diseases, and who is group risk? Medical personnel who have contact with ill persons. Usually it is surgical, operative gynecology, operative stomatology, surgery, and who work in the hemodialysis departments, who work in the hemotransfusion departments, who have contact with blood, contaminated blood, who have contact with ill persons, persons with chronic viral hepatitis. And patients with acute and chronic hepatitis B are susceptible to Delta infection. It is epidemiology. But doctors, I said you artificial, yes, hemodialysis and injections, medical procedures who have like multiple procedures of beauty, for example, injection of beauty, yes, revitalization and injection of Botox, multiple, when needles is don't sterilized, and cuts, manicure, pedicure, and doctors. But nature calls way, it is sexual way. But the second nature way, what is? Vertical from infected mother, registered rare, because rare registered women with hepatitis B and Delta virus. It is severe cause of disease and usually characterized high percent mortality who infected acute viral hepatitis B plus Delta, and together prognosis very bad, and this patient don't may keep pregnancy newborns. It is actuality and epidemiology, Delta viral infection. I have questions. And doctors, you must know who is group risk. Humans with who infected B virus. Necessary to develop infection process B virus. And two variants. When patient infected two viruses together, B and Delta, for example, patient had multiple hemotransfusion and infected two viruses together. It is diagnosed co-infection. And it's now a name from International Classification of Diseases, acute viral hepatitis B with Delta agent. When patient infected two viruses together, it is co-infection and diagnosis. First time patient infected B virus, acute viral hepatitis B with Delta agent. When patient has chronic viral hepatitis B, has many years, and infected Delta virus, its result may be sexual contact, unprotected sexual contact, or for example, examination of stomatology and invasive examination, infected Delta virus, and its diagnosis will be superinfection. And from international classification, it is diagnosed acute Delta viral hepatitis patient with HBs antigen. Acute Delta viral hepatitis Delta patient with Delta antigen, with HBs antigen, sorry. Acute viral hepatitis Delta patient with HBs antigen. And you'll now continue to discuss. And doctors, pathogenesis. Doctor, you know from pathogenesis viral hepatitis A and B, immune system must be detected this virus as another and phagocyted as a virus, and together to stop liver cell where virus present. Virus replicated in the hepatocytes from blood, from disturbances of mucous membrane. Virus goes through the bloodstream and presented in the hepatocytes and replicated in the liver cells, but virus himself affected hepatocyte. Virus has direct cytopathic effect, and together immune response affected liver cells where present virus. Why? Because necessarily eliminated virus, but it is another antigen. And what is appeared? Two ways. affected hepatocyte, direct cytopathic effect of hepatitis delta virus, and immune-mediated cytolysis of virus-infected hepatocyte, and total liver cells infected. You discussed viral hepatitis B. Only one mechanism. What is indirect cytopathic effect when cytotoxic lymphocytes and natural killer affected liver cells. But when developing delta virus infection, virus himself affects hepatocytes, and during short time, 2 times higher affected liver cells, and developing necrotic changes in the liver tissue. And you understand why delta viral hepatitis characterized severe cause, percent severe cause very high than hepatitis B. I'm not saying. I have questions about pathogenesis, and doctors, I said you, from all viral hepatitis, high percent severe cause, bad prognosis as viral hepatitis delta, co-infection and super-infection. Why? Because 2 ways affected liver cells during short time. And usually prognosis of delta virus hepatitis bad, 25% registered fulminant cause of disease when outcome death, and percent chronization increased to 80%. And I said you, against viral hepatitis, who infected viral hepatitis A, fulminant cause registered 0.01%, rare cases. To the hepatitis B virus characterized 1% developing acute encephalopathy. But to delta viral hepatitis, 25. It is, you understand, each 4 human that who infected delta viral infection. And it is a characteristic severe cause. And now you must discuss each variant of delta viral infection, co-infection and superinfection, if you understand pathogenesis. And doctors, if virus affected himself, direct cytopathic effect, affected deeper structure of hepatocyte, because you know immune-mediated immune response, what is affected only wall of the hepatocyte. But virus, when affected virus in the cell, yes, and affected by the cell, affected deeper structure, what is complex Golgi and mitochondria. And from the chemical test, you know, where present ILT? ILT in the cytoplasm. When the dystopes of all of hepatocytes, usually ILT level go to the bloodstream, and ILT level higher than IST. Where IST? IST on the membrane of hepatocyte. But when affected deeper structure of hepatocyte, IST in the deeper structure of hepatocytes, in the mitochondria, in the complex Golgi. This situation, IST level will be higher than ILT. To delta viral infection, characterized usually when you examine biochemical test, ILT level higher than IST. For example, ILT 1,500. But IST 1,000. But when you examine IST 2,000, ILT 1,000, you understand all hepatocytes affected deeper structure hepatocyte. You understand me? Okay. And it is pathogenesis. Next, clinical picture common for all viral hepatitis affected liver and characterized pre-ecteric period and ecteric period and incubation. Doctors, pre-ecteric period usually as prefectory periods of viral hepatitis B, characterized dyspeptic variant, this stops detoxification function of the liver, after a vegetative variant, and two variants when virus persistent, developing immune complexes, and what is variants? Arthralgia and exanthematose when developing rash, toxic allergic rash. And doctors, incubation period of co-infection lasting from 6 weeks to 10 weeks. How many? 1/2 month to 2 months, 2.5 months. It is incubation period. And after developing clinical picture. And what's mean co-infection? Please tell me, repeat. Together, and together. But doctors, two viruses present in human body, but what is virus first time must be replicated? B or D? B, yes, because to delta virus necessary HBs antigen. And delta virus waiting when we keep good high level HBs antigen to cover and presentate it to hepatocytes. Yes, and virus present, but don't make high presentated because concentration HBs antigen now low. And patient infected, a clinical picture acute viral hepatitis, you examined, you detected high-level cytolysis, and you think about diagnosis acute viral hepatitis, you administer ELISA examination, and from ELISA examination, what is markers are you detected? If replicated virus hepatitis B, HBe antigen, marker replication virus, and another.
Yes.
HBs antigen. It is couple virus necessary for all viruses B and Delta, and IgM. Yes, antibody HB core, immunoglobulin M. And you, right, acute viral hepatitis B confirmed occurs HBs antigen plus antibody HB core, immunoglobulin M. But against background therapy, patient condition was maybe short-term decreased intoxication, short-term decreased transaminase activation. For example, ILT was 2,000, after 1 week decreased to 1,800, but when you repeat administer second examination, increase ILT and IST, but before detected biochemical test, patient's condition was patient has multiple vomiting. The patient condition was and bed of sleep. And you understand, it's maybe what is severe cause of viral hepatitis B, but it is second wave of the disease. Short time decrease intoxication syndrome, but next repeat increase. It's the second wave of the disease, and you must be examined the Delta virus. And when you examine it after 3-4 weeks of onset of the disease, you detected markers acute viral hepatitis Delta. What is markers of acute viral hepatitis Delta? Antibody, HDV immunoglobulin M, and antibody HDV later immunoglobulin G. And immunoglobulin, it is acute phase of a disease. But before synthesis antibodies, you detected RNA. Patient infected two viruses together, and RNA HDV present. Only low, moderate or low, but when replicated Delta virus, increase RNA. And doctor, serological profile. First days of the disease, you detected markers acute viral hepatitis B, HBs, antigen and antibody HB core immunoglobulin M, antibody HB core immunoglobulin M. And after 4 weeks, you detected antibody HDV immunoglobulin M, and later antibody HDV immunoglobulin G. First days of a disease, you don't detect antibodies against Delta virus because necessary time to cover these viruses and present it to liver cells and replicate. But doctors, I said Delta viral infection characterized severe course and 25% registered outcome encephalopathy, complication encephalopathy, and outcome will be lethal. And what patient said, you confirm diagnosis acute viral hepatitis B, but pathologanatomy examination said to you mistake because you don't detect Delta virus. In the hepatocytes, in the section detected RNA HCV. And my recommendation, when patient has severe crossover disease, antibody synthesis later, you must be examined to RNA HCV, administered PCR together. Because antibodies will appear after 3-4 weeks onset of the disease later. You maybe don't detect it, but outcome will be better. And what is prognosis co-infection? As viral hepatitis B. Prognosis of acute viral hepatitis B, 95% recovery, 5% chronization cost. In this case, 5% recovery, 5% chronization cost, 80% recovery, and 15-20% developing acute hepatic encephalopathy, severe cause. Because co-infection delta characterize severe crossover disease. Why you now? Bronchophagogenesis. If total during short time affected 2 times higher liver cells than viral hepatitis B. Direct effect of virus and indirect effect of immune system. Do you understand? Okay. And in our situation, when patient has superinfection delta, what's mean? Against the background chronic viral hepatitis B, patient infected delta virus. Patient hospitalized in your clinic with clinical picture acute viral hepatitis. When you administer laboratory test, you detected markers chronic viral hepatitis B. What is markers chronic viral hepatitis B? Please tell me. HBs antigen and what is IgG? What's markers? IgG, many IgG, I don't understand. Antibody, HBC, HB core or HBC, immunoglobulin class G. It's markers chronic viral hepatitis B. And you think, why? Patient has clinical picture, acute process, transaminase activation very high, but markers chronic viral hepatitis B. It don't correlate. Because when developing chronic process, absent intoxication syndrome, marked intoxication syndrome, absent marked jaundice, and absent marked hydrolysis. Usually, when patient has chronic cause, transaminase activation hundreds, 100, 300, 400, but you detected 3,000, 2,000 level ILT and IST. You must examine it to another viral hepatitis and first time Delta virus, because group risk of Delta viruses, humans with chronic HBV infection. And first days of a disease, you detected markers Delta viral infection. What is markers? Acute antibody, HDV, immunoglobulin M. Patient has HBs antigen, HBe antigen, antibody HB core immunoglobulin G, and first days you detected antibody HDV immunoglobulin M and immunoglobulin G. Plus you detected from PCR, RNA, HDV. And doctors, its name, superinfection, and our acute viral hepatitis delta patient with HBs antigen. What I say you when you discuss the B virus, HBs antigen carrier is not healthy process. Yes? It's group risk to infect with Delta virus. If HBs antigen persistent, patient has chronic persistent viral hepatitis. not only necessary time to activate Delta virus, activated B virus. And prognosis, bad. Don't develop in recovery. Why? Patient immunocompromised. Immune system is not effective if virus hepatitis B persisted, developing chronization course. And characterized 80% chronization course and 20-25% fulminant course. And maybe developing result acute viral hepatitis delta, complication acute hepatic encephalopathy, and after will be outcome that or developing chronization cause. Recovery, don't develop. 80% chronization and 25% acute hepatic encephalopathy. Why developing acute hepatic encephalopathy? The result, hyperactive immune response, developing fulminant post-COVID disease. Together here, IgM and IgG. Yes, because don't necessarily this replicated result when co-infection, first time replicated B virus, but to this time Delta virus don't wait and when keep H-based antigen and would replicate it and developing together antibodies plus F and G. Copied? Okay. And doctors, from all viral hepatitis, please remember, viral hepatitis B characterized bad prognosis, characterized high percent developing fulminant post-COVID disease. And doctors, when developing chronization cause, after 3-5 years, developing decompensation cirrhosis, virus very teratogenic. Patient don't live to developing hepatocellular carcinoma. You know, to developing hepatocellular carcinoma, virus must be persistent 20 years and more. This time absent to our patients. After 3-5 years, developing cirrhosis. Usually, it is a short period of decompensation characterized to East humans. For example, in our clinic, patients from Azerbaijan, Tajikistan, repeat hospitalized with cirrhosis after 3-5 years. 5 years ago, patient had acute viral hepatitis delta, but after 3-5 years, hospitalized when developing decompensation cirrhosis. To European patients, it is median in degree increased to 5-10 years, but outcome will be bad, developing cirrhosis, decompensation cirrhosis. Virus very teratogenic. Why? It is change different time of decompensation connected with tissue histocompatibility. And doctors, laboratory test, please repeat. The acute hepatitis B with a delta agent, it is diagnosed international classification, acute hepatitis B with a delta agent. Another co-infection. You detected first days of the disease markers acute viral hepatitis B, and later, when developing second wave of the disease, after 2 or 4 weeks, you detected markers acute viral hepatitis delta antibody HDV immunoglobulin M, and later, after 3-4 weeks of onset of the disease, you detected antibody HDV immunoglobulin G. It is markers co-infection. Online doctors, are you see presentation?
Yes.
Yeah.
Yeah, it is.
Are you copied?
Yes.
Are you have questions?
No,
What is fast and difficult for you?
I think it's pretty clear now. No.
What is?
Um,
Doctor,
It's clear. No questions.
No questions. Okay. Will be many questions in the practical lessons.
Doctor, in the laboratory test, how will we know the difference between if our patient is infected B or delta?
No, doctors, usually principle, it's when hospitalized patient, gold standard examination to free viral hepatitis A, B, and C, registered in the worldwide. And you detected markers B virus. And next rules, you must be examined to Delta virus. It is common principle now. Because before detected markers B viral hepatitis don't necessarily examinate it to Delta virus. But you, co-infection, you examinated, markers absent. Because you know, antibodies appear later. I said you, yes? But patient condition worse, appear second wave of a disease, it's necessary repeat administer examination to Delta virus. And when patient has chronic viral hepatitis, you understand this group is necessary examination. And principle with rules in the world, if you detected HBs antigen, markers viral hepatitis B, necessary to give examination to Delta virus. Okay, and doctors, please look, markers, sorry, where is? Acute viral hepatitis delta and superinfection delta. You know, against the background markers, chronic viral hepatitis B, HBs antigen and antibody IgG core immunoglobulin G. First days of the disease, you detected markers acute viral hepatitis delta because don't necessarily time to keep HBs antigen. And incubation period of acute viral hepatitis delta lasting 3-4 weeks. And superinfection, another name, acute delta infection of hepatitis B virus carrier or of HBs antigen patient. Copied? Symptoms, it's common. And first, it is each patient individual, yes? Who have, for example, 3 weeks incubation period, who have 4 weeks, 6 weeks, it's each patient individual. And clinical picture, first time, pre-ecteric period, and you understand to Delta viral infection, characterized prevalent ecteric form, because total liver cells affected if developing necrosis. And clinical picture, pre-ecteric period, what is? I said you. Dyspeptic, arthralgia, astenovedative, and exanthematose. And doctors, if developing necrosis maybe increased temperature. Usually clinical picture viral hepatitis characterized absent fever, but when developing necrosis, increased temperature. And after period jaundice, I said you clinical picture common, but how many times lasting each period? It is connected with humans, individuals. And doctors, please copy outcomes. I said you, but repeat. Patient has co-infection. Recovery 75%. Chronization 5 to 10% as after acute viral hepatitis B, and fatal outcome result developing extrahepatic encephalopathy 20-25%. And who infected against the background chronic viral hepatitis B Delta virus? prognosis is bad. Fatal outcome 30% and chronization 80%. And with rapid formation, cirrhosis. COVID. And doctors, what is prevention? If humans vaccinated against virus hepatitis B together, it is prevention against Delta virus, and it is prevention against co-infection. But who have chronic HBV infection, chronic viral hepatitis B, it is group risk infected Delta virus. Vaccine against Delta virus absent. And our recommendation, the change behavior of our patient. If our patient using narcotics, so injection narcotics. Or, for example, patient's behavior, multiple sexual contact, stop this behavior and use recommended barrier contraceptives. And these persons must be now with group risk infected Delta virus and prognostic superinfection is bad. Will be outcome death and recommended. And usually, who like go to the beauty salon, recommended. This necessary to go to only very controlled salons, don't at the home. For example, in our clinic, hospitalized younger woman with co-infection Delta, B plus Delta. It is work manicure at the home. But who is infected this woman? Boyfriend was drug addict and from sexual contacts infected this woman. But this woman don't sterilize with instruments, and you understand, maybe infected persons who had this manicure. And outcome this woman was bad, lethal case, severe cause of disease. But boyfriend had chronic viral hepatitis B plus Delta. So usually who is using narcotics, immune system is not good response and developing chronization cost. Don't active response, don't affect all liver cells. And with men had only a chronization cost, but women had acute course and outcome was better. Have you questions about viral hepatitis B Delta? Okay. Doctors, have a rest 10 minutes. This theme is difficult, necessary repeat information about B virus. And after 10 minutes, we'll be discuss complication of all viral hepatitis. What is complication? Acute hepatic encephalopathy. You must be discuss pathogenesis and clinical picture. 10 minutes rest. Doctors, are you listening me?
Yes.
Yes.
After 10 minutes, please return to Zoom link.
Okay.
Morning, doctors. In this scheme, full information of pathogenesis, acute encephalopathy. Russia, but I translate for you. And doctors, in the large intestine, what is present? Products of protein metabolism. And what is in our name? Ammion, ammonial compounds. Ammonial compounds, it is a product of protein metabolism. And at venome, these ammonial compounds from rectal vein go to the bloodstream, it is vena porta, and from vena porta go to the liver. A healthy liver, detoxicated ammonial compound. What is in the liver synthesis? Urea. And ammonial compounds neutralized. But liver cells affected and don't make synthesis urea. And ammonial compounds go to the bloodstream and go to the cerebral cortex. And developing disturbances of potassium kalium ataphase and change, decrease potassium in the cortex brain cells and increase sodium. And what do you do? Sodium. Usually, when you drink salt product, add salt products, what do you want? Well, drinking, yes. And so sodium taking water. And what is it? Edema of the brain cortex. Doctors, it is common mechanism of encephalopathy. Monday will be discussed malaria. And when developing cerebral form, tropical malaria, falciparum malaria. And it's basic, pathomorphologic, basic of all encephalopathy, toxical, alcoholic encephalopathy. It is brain edema of the cortex. When disturbs not potassium, sodium, ataphase, and increase sodium in the cells, but deficit potassium, and developing edema. And doctors, if this mechanism, you understand what is therapy necessary administered from this scheme, where problems, where present large intestine, but when you ammonial compounds, it is products of protein, necessary decrease protein in the food, yes, but together you know protein necessary to synthesize antibodies, but necessarily limited dose of protein, but ammonial compounds in the large intestine, necessary evacuated large intestine. What is therapy necessary administered? What is remedies necessary administered? Remedies. Lactulose, Dufalac, it is a drugs have what is asthmatic diarrhea, yes? With aim asthmatic diarrhea. To us necessary developing asthmatic diarrhea of our patient. And together, you know, if ammonial compounds go to the cortex and developing edema, you must administer potassium keep diuretics. And together you must administer potassium drugs because potassium decrease. And it is, if you know pathogenesis, you understand what is signs of clinical picture developing and what is remedies necessary to administer. And it is theory, ammonial compounds theory. Ammonial compounds theory. Theory, pathogenesis, two theories. And second theory, it is endotoxical. Because in the large intestine, in the feces, present gram-negative bacteria. And gram-negative bacteria synthesis endotoxin, lipopolysaccharide. And at the known, endotoxin go from rectal vein to the bloodstream, and from vena porta go to the liver and must be neutralized. But liver cells affect. And this endotoxin irrigated Kupffer cells. And Kupffer cells synthesis cytokines. Cytokine necessary for human. Why? Cytokines, rules of cytokines, it is immunoregulator. But this time, synthesis irrigated Kupffer cells, level cytokines very high. And what is appear? This stops immunoregulator, and synthesis interleukin 1 beta. What do we do with interleukin 1 beta? It is interleukin 1 beta answer to differentiation toxic lymphocytes. And activated cytotoxic lymphocytes. What do you do with the toxic lymphocytes? Affected liver cells were present virus. And total affected liver cells were present virus. Don't keep, for example, usually moderate cause, one part of liver cells affected, next day, next part. But total liver cells affected because level cytokines very high. And together, synthesis interleukin 6. Interleukin 6 responds to B cell lymphocytes response. And synthesis, what is immunoglobulins, high-level immunoglobulins, immune complexes, and together developing antibody-dependent cell cytotoxicity, affected liver cells. Total liver cells affected, developing necrosis. Virus, from pathogenesis, developing cytolysis of hepatocytes, but 100% all liver cells affected and developing necrosis liver. And doctors, you understand what is therapy necessary administer to stop synthesis cytokines? Who is irrigated Kupffer cells? And the toxin from gram-negative bacteria. Where gram-negative bacteria? In the large intestine. You must administer asthmatic diarrhea drugs and evacuated not only ammonial compounds, and together evacuated gram-negative bacteria. And together you must administer antibiotics with low resorption in the small intestine. It is rifaximin. And why low resorption? Don't affect enterocytes and go to the large intestine. And inactivated gram-negative bacteria. And if you inactivated gram-negative bacteria, stop synthesis endotoxin. And doctors, from pathogenesis, you understand what is remedies necessary administer. And asthmatic diarrhea drugs, antibiotics with low resorption of the small intestine, and necessary administer diuretics with function of keep potassium and potassium drugs. And together, doctors, result bacterial hydrolysis in the large intestine, developing fat acids. And fat acids, it is basic to synthesis mercaptans. What do mercaptans? It is toxical effect of the brain for neurotransmitters. And together, developing the stops of amino acids, increased aromatic amino acids and drop branch amino acids. And when increase aromatic amino acids, it is basic to synthesis false neurotransmitters. It is beta-phenylethanol-amine and octapamine. What do we do with false neurotransmitters? Disturb central nervous system and developing usually it is emotional lability, affected psychic function, disturb psychic function of the brain, and developing clinical picture. And are you wanting? And doctors, if decrease branch amino acids, you must administer intravenous branch amino acids to prevent increased false neurotransmitters. You understand? Not fully. Why? What is problem? Fatty acids, yes. Fat acids result hydrolysis bacteria. And fat acids, it is basic to synthesis mercaptans. And together result this hydrolysis disturb balanced amino acids, increase aromatic amino acids, and decrease branch amino acids. But aromatic amino acids from aromatic amino acids synthesis a false neurotransmitter. What is false neurotransmitter? Beta-phenylethanol-amine and octapamine. And usually this is false neurotransmitters concurrent with active neurotransmitters. What is adrenaline? And these false neurotransmitters affected central nervous systems and developing psychic disturbance, irritation, aggressive, emotional lability, apathy, and developing clinical picture, signs of encephalopathy. And clinical picture, doctors, when developing first stage encephalopathy, pre-coma 1, your remedies will be effective. But when administered proper coma, our remedy is not effective and outcome only one, death. And necessary now, first signs of encephalopathy to administer rapid administer therapy. And please look, what is first signs of first stage? Apathy, agitation, anxiety, fear. But doctors, first sign of first stage of encephalopathy, pre-coma 1, it is disturbance of sleep, inversion of sleep, sleepless at the day and insomnia at the night. And appear tremor, dysarthria, impaired coordination, and hyperreflexia. And tremor of the finger, tremor of the tip of tongue. When you examine tongue, tremor tip of tongue, tremor of the finger. And doctors, appear hepatic smell. What does mean hepatic smell? It is result disturb of the liver. What is morphological basic of the liver? No, it is function. Morphological structure of the liver. What is? For example, heart, it is muscle, yes? But what is liver? What is tissue of liver? Glycogen. It's another name. What is sugar? Yes, disturbs glycogen appear as smell as unrotten apples. apples. As a smell, when you breathe it, it smell as rotten apples. Rotten. And other fruits. Because what is basic, but morphological basic of the liver structure? It is glycogen. Glycogen in our name, what is? Sugar. And when you close room in the morning, you go to the exam patients and you detected hepatic smell. It is what is smell as rotten apples. And this patient must be first-time examined because this patient has encephalopathy. And patient emotional lability. Now maybe funny and after only apathy. It is first stage. And doctors, you know, first function of the liver, it is detoxification, but next function of the liver, what is? Protein synthetic. And result affected hepatocyte, disturbed protein synthetic function, and disturbed coagulograms factors of coagulogram, and developing what is the syndrome if result disturbed hemorrhagic syndrome, yes, and you detected hemorrhagic rash, petechias, when the place of pressure, for example, over bowel, and when you examined BP, you detected hemorrhagic rash. On the place of injection appear hematomas because disturbed coagulation, and appear nasal bleeding, gums bleeding. It is signs of severity. Doctors, when you detected signs of hemorrhagic syndrome, it is severe course of a disease. But you don't know what is a patient condition. It's only clinical information, clinical science. You must confirm from laboratory. Please remember, laboratory criteria severity, it is prothrombin index. From coagulogram, you detected prothrombin index. It is adequate information of severe course of a disease. Because patient may be safe for you. I have gums, or maybe don't say for you, hence nasal gums, nasal and bleeding and gums bleeding. But objective, it is laboratory analysis. Laboratory criteria severity, prothrombin index. Normal prothrombin index 75. When prothrombin index decreased to 60, it is critical and necessary every time monitoring and exam patient, and maybe 2 times every day, administer exam prothrombin index. Because what is EPA? It is disturbs liver, disturbs function of the liver, and developing bleeding, massive bleeding, uterine bleeding, intestinal bleeding, stomach bleeding, edema, hemorrhagic edema of the lungs. And when drop prothrombin index, you must be administered hemostatic therapy, chilled plasma. And when you administer chilled plasma, when prothrombin index decreased to 40% and less. Before for decrease 40%, you must be administered amino acid solutions, branch amino acids. And doctors, on the first stage of hepatic encephalopathy, appear first signs of hemorrhagic syndrome, what is petechias, nasal and gums bleeding, and decrease prothrombin index to maybe 60, don't drop, decrease only. But when developing second stage of the encephalopathy, developing somnolence, patient disorientated in the time, in the space, developing apathy or aggression, hyperreflexia and ataxia. Patient don't understand where door of the room and where window, and maybe go out from building, from window. And what is that? And patient understand where bed of the room, and maybe go to another bedroom. It is disorientation. At this stage, you may be helped with your remedies. But when developing proper coma, absent liver, necrosis, total necrosis of the liver, and outcome only the stupor, disorientation in space and time, hyperreflexia, pathological reflexes, myoclonus, delirium, and hyperventilation. And doctors, this albumin drop, protein synthetic function stopped, and developing a dermatoacidic syndrome. It is developing ascites and appear edema of the lungs, hemorrhagic edema of the lungs, and appear massive bleeding, uterine, intestinal bleeding, and coma will be one that when developing a proper coma, third stage of encephalopathy. Massive bleeding, it is characterized as third stage. Nasal bleeding, nasal bleeding, gums bleeding is first stage of encephalopathy, but massive bleeding characterized the third stage. COVID? Okay, I have questions? Online doctors, I have questions? Okay, if absent questions, continue our discussion. Next, third, parenteral viral hepatitis B. We discussed viral hepatitis B, Delta, and third, viral hepatitis C. Doctors, viral hepatitis C characterized subclinical cause, prevalent subclinical cause of a disease. Why? You must now discuss. Please look definition. What's mean viral hepatitis C? Hepatitis C is a human viral disease characterized by hepatitis, a high incidence of anecteric forms in the acute phase of infection, and the frequent formation of chronic hepatitis with a possible development of liver cirrhosis and hepatocellular carcinoma is subsequent. Result, persistent many years, virus hepatitis C, developing cirrhosis and developing hepatocellular carcinoma. Usually, acute viral hepatitis C registered 5 to 10%, and chronic viral hepatitis C registered, detected after laboratory examination. What is characterized? Patient condition good or satisfactory. Absent complaints, only planned laboratory examination detected markers viral hepatitis C. And this first time patient listen this information because without clinical picture, acute viral hepatitis. It is after laboratory examination. For example, plan hospitalization to therapeutic to surgical department, and patient examined and detected markers viral hepatitis C. And please look, natural development, viral hepatitis C, cirrhosis of the liver, and the risk of development, hepatocellular carcinoma. Human infected viral hepatitis C, developing acute infection, and spontaneous recovery registered 15 to 35%. Doctors, 45%, it is good prognostic figure. Usually 15% spontaneous recovery. 15 to 45. If you want, please turn off light. Doctor, please turn off. Thank you. usually developing chronization cause of the disease, and chronization has registered to 85%. It is high, 85% chronization cause. And this disease characterized persistent virus hepatitis C, moderate or severe cause, and after during 20 years, developing cirrhosis, and after decompensation cirrhosis, or developing hepatocellular carcinoma. Prevalent cirrhosis, 15 to 30% registered cirrhosis, and 2 to 5% registered cirrhosis. And doctors, please look at this change character of the liver. And my question, what do you think? Why do viral hepatitis C characterized high% chronization cause? It is RNA virus. You know, DNA viruses integrated in the host genome. It don't may leave our body, but RNA virus, why developing chronization? Why immune system may eliminate the virus? What is it? Mutated, every time mutated. Virus every time mutated. And mutation rate very high than rate replication. And please look, doctors, etiologic characteristic virus hepatitis C. Doctors, virus hepatitis C from the family Flaviviridae. From this family, Flaviviridae, viruses of what is yellow fever and dengue fever. It is characterized marked clinical picture, but and viral hepatitis C from this. Hello. And but to viral hepatitis C, different than, for example, fever viruses, subclinical cause of a disease. And it is spherical particle with 42 to 50 nanometer in diameter. The genome is represented by a linear plus RNA chain consisting of 9,500 nucleotides and high mutation variation over hepatitis C virus genome. Doctors, in this time, registered 8 genotypes, but each genotype has many subtypes. Plus, look, genotype 4, how many subtypes? Genotypes first, how many subtypes? Genotype second, how many subtypes? It's only you now, because every year registered new genotypes. Please look my slide 5 years ago. Only registered 6 genotypes, and first 3 genotypes, first, second, and third registered in the world. 4 genotype in the Egypt. It is usually North Africa, and in the South Africa registered 5 genotype, geographical prevalent region, and 6 genotype registered in the China. And it is a disease parental. Who is group risk? You know from viral hepatitis B, who has multiple injection, who has multiple hemodialysis, a hemotransfusion. It is drug addict person's first time. And drug addict person may be infected 2 or more genotypes and subtypes of virus. And you administer therapy, but therapy will be not effective because our patient may be infected another new subtype or subtype of virus. And doctors, please look where percentage of people infected with hepatitis C annually. Where prevalent? Russia Federation, East Europe. And Egypt, yes. And but genotypes first characterized together and high rate mutation than another genotypes. It's actuality of disease, and virus is don't resistant than viruses B and A. It is inactivated body in 2 minutes, and pasteurization during 30 minutes, virus inactivated, and ultraviolet rays lipid solvents inactivated virus. It is pathologic characteristic of virus, and usually who is infected? Infected dose of virus hepatitis C, 10^5 to 10^6 power. You know, infected dose of viral hepatitis B, 10^3 to 10^4 power. I said you only 1 drop of blood and developing clinical picture. But to infected virus hepatitis C must be large dose. And who is infected? Usually who have multiple sexual contacts with the stops of mucous membrane of genitalis, where present genital infections. Usually it is prostitute groups, and who have multiple injection. It is drug addict persons, and who had profuse hemodialysis, multiple hemodialysis, it profuse hemotransfusions, large dose of hemotransfusion. But who work in the medicine, usually rare infected, because it is necessary multiple contact with this virus hepatitis C. And doctors, constant sexual partners, for example, wives and their husbands, during many years, don't infect virus hepatitis C. And from placenta, virus pass only 5%. Only 5% newborns infected virus hepatitis C. But when increase percent infected virus hepatitis C of newborns, when mother continue use narcotics during pregnancy, and increase percent infected virus hepatitis C. When mother infected HIV, it is 25% newborns infected virus hepatitis C and HIV together from placenta. But if mother has only a hepatitis C virus, a newborn is not infected. It's necessary only high load HCV RNA. But usually when pregnancy period, load viruses B and C decrease. It is nature prevent newborns. But if HIV and drug addicts, it increase the risk infected newborns. And these doctors look epidemiology. The source of hepatitis C virus infection is patients with acute and chronic viral hepatitis B. The mechanism of transmission of hepatitis C infection is parenteral, and concentration virus in the blood 10^4, 10^5 or 6 power. Necessary large dose. 10^4, 10^6. And who's group risk? Drug addict persons and sexual partners of drug addict persons, sex workers and their sexual partners, men who have sex with men, persons with a large number of random sexual partners, where disturbs mucous membrane of genitalis, and persons serving a sentence of imprisonment, where maybe injections and a typical sexual contact. Who in the prisons? Okay, I have questions about epidemiology? No. And please, doctors, look structure of virus hepatitis B. Doctors, penetration factors, it is capsid protein and envelope glycoproteins, E1 and E2. Usually it is structural proteins, and envelope 1 and envelope 2 every time mutated. And you understand, it is superficial proteins, and every time mutated, you don't make synthesis vaccine against viral hepatitis C because enveloped every time mutated. It is penetration factors every time mutated. But non-structural proteins, it is replication factors, NS2, NS3, NS4, and NS5. And doctors, it is a proteins necessary to enzymes reaction to replication virus. And NS5B RNA dependent RNA polymerase, necessary basic enzyme to replication virus C. And our modern therapy, it is therapy against replication factors, against non-structural proteins, inhibitor non-structural proteins, and first time NS5B, inhibitor of RNA polymerase. When you administer inhibitor of RNA polymerase, stop replication virus. If stop replication, human donated and developing recovery with our modern therapy. Do you understand me? Why necessary now for you structural virus and penetration factors every time mutated. We don't make preventive against, don't make synthesis remedies against penetration factors. But against replication factors, you now have direct antiviral therapy. And mechanism of a disease. Doctors, usually 5% reduced acute viral hepatitis C. Prevalent 90-95% chronization cause. Patient had infected and without clinical picture, absent clinical picture. And virus persisted, but don't develop a clinical picture. Why? Doctors, when developing clinical picture, when immune response adequate, when immune response detected virus and synthesis cytotoxic lymphocytes and antibodies against this virus. But what do you do virus? Mutated. And T cells don't find this virus because every time virus mutated and virus don't replicate in the liver cells and keep in the prevalent zones. And virus, if don't detect it, absent cytolysis of hepatocytes. If absent cytolysis of hepatocytes, absent clinical picture, but virus persistent. And together, virus every time mutated and developing against viruses antibodies. Tell me please, what is class of immunoglobulin synthesis against virus every time? That's very good, IgM. And IgM connect antigen, but this connection is not effective. And it is complex, sit in the wall of vessels and presented to tissue of joints and developing this complexes sit on this in our tissues and developing extrahepatic manifestations and developing system diseases. Next, to HCV infection, no viral hepatitis in our name, because virus persists and developing HCV infection. And immunoglobulin M have common structure with cryoglobulins and rheumatoid factor. Okay, girls. Continue. Discuss. Doctors, virus every time mutated against virus synthesis antibodies. If the antibody connect antigen, but if this connect is don't affect. Virus don't, this antibodies is don't may eliminate it with virus because change structure of a virus. And it is antibodies immune complexes presented on the human tissue. What is first time? It is wall of vessels and tissue of joints and developing systemic diseases. Next, and usually viral hepatitis HCV infection characterized developing systemic autoimmune diseases and developing oncology process, lymphoproliferative diseases. Why? You understand why developing systemic. Next step. Immunoglobulin, every time synthesis immunoglobulin M. Immunoglobulin M have common nature with cryoglobulins and rheumatoid factor. It is developing what is diseases? Autoimmune diseases. And you understand, if a virus persists 10 years and more, developing autoimmune diseases. And who is synthesizing immunoglobulins? What is cells of our body synthesize immunoglobulins? B cells. If B cells every time, every day, synthesis immunoglobulins class M, you know, immunoglobulins class M large than immunoglobulin G. Yes? Because, why large? Because, largest. Because first information, what is another antigen present in my body, yes? And you don't know, cells don't know what is the structure of virus. And since it's maximum large immunoglobulin to connect with antigen. And when take information, what is the structure of antigen, synthesis specific immunoglobulin G, small, large. Of antibodies, but every time synthesis immunoglobulin class M and large. And what is appear after 10, 20 years? Dysfunction B lymphocytes and developing B lymphoproliferative diseases. And usually chronic HCV infection, it is systemic diseases, autoimmune diseases, and last end stage, it is lymphoproliferative diseases. But don't develop a clinical picture every virus. Virus persists. And please copy a scheme of pathogenesis. Virus hepatitis C from the blood enters the hepatocytes and organs of the synthetic macrophages system. Virus replicated in hepatocytes and have direct cytopathic effect. Virus has direct cytopathic effect. But virus hepatitis C replicated in immunologically preferred zones, prevalent zones, and developing dissemination, virus hepatitis C in other organs and systems, and immune slipping away of hepatitis C virus and decreased immunogenicity. And virus every time mutated and with suppression of cellular and humoral immunity. And results suppression, humoral and cellular immunity don't develop in clinical picture, absent cytolysis, but virus persistent. I understand? Yeah, virus mutated, and these cells don't know what to do, yes, and don't affect it with virus, and persistent and low replication. In hepatocytes, yes. Virus replicated in hepatocytes, but maybe replicated in another organ system, usually disseminated, and immune complexes presented to all organs and systems. And you know, what is clinical picture HCV infection? It is a systemic autoimmune and lymphoproliferative disease. And acute viral hepatitis registered rare 5 to 10%. When will be adequate immune response and T cells and B cells affected, the liver cells were present virus. Copied? And doctors, it is a clinical picture. Acute viral hepatitis clinical picture common. Yes, incubation period. Usually, if don't affected liver cells, prevalent anecteric cause of the disease. Rare registered from 5% anecteric cause prevalent and ecteric cause registered rare. Patient has only intoxication syndrome and maybe mild or moderate jaundice. But when the patient has intoxication syndrome, clinical picture of hepatitis, what is detected? Increased liver and increased spleen sizes, and hospitalized, you exam, and detected there is a high level transaminase activation. It is what is catalytic syndrome, yes? And maybe level bilirubin 2 times higher, 3 times higher, 60, 40, don't increase more 100. And you understand, because absent marked cytolysis. And you administer gold standard examination to viral hepatitis A, B, and C. And all markers negative. And what do you think? It is diagnosis will be acute viral hepatitis and no etiology. But antibody synthesis later, after 3-4 weeks, you detected antibodies later, this titer of antibodies. And epidemiological service controlled work of infection diseases doctor. And epidemiological service say, please exam to HCV RNA. When you exam HCV RNA, administer PCR, you detected HCV RNA. And doctors, this situation when absent markers viral hepatitis, you must administer examination to HCV RNA because antibodies synthesis late. And you understand why? Because virus every time mutates, yes, and necessary time to synthesis. And after you detected antibody HCV total. And doctors, from this slide, you detected antibody HCV to markers of past or current infection. You detected antibodies, but you don't know what is antibodies. Post-infection immunity, or maybe cross antibodies, because why cross? Virus mutated, and antibodies against virus C, maybe against virus adenoviral, because virus mutated, cross response, and maybe patient infected. Maybe it is a mistake of the test system, and from antibodies, you don't make confirmed diagnosis. You confirm diagnosis when you detected HCV RNA. When you detected HCV RNA, yes, diagnose HCV infection, acute viral hepatitis C or HCV infection. It's coming to the clinical picture and objective data. And Please remember, antibody HCV, it is only screen examination. It is one step of examination. But later, you must administer PCR. I said you to confirm diagnosis viral hepatitis A and B, and B PCR only additional test. But when you examined patient with hepatitis C virus, basic test PCR. And please look, scheme of a disease, acute phase of a disease when patient infected, a high load HCV RNA, high level ILT, cytolysis, and you detected high level antibody HCV immunoglobulin M and together synthesis immunoglobulin G. It is acute phase lasting 6 months. After 6 months, concentration HCV RNA decrease, usually 10 over 2 power, 10 over 3rd power, and transaminase activation normal or moderate increase, and antibody HCV immunoglobulin level low. Why? Because absent high level replication. And you detected antibody HCV immunoglobulin G. This time when patient examined, absent clinical patient condition good. And for example, a laboratory examination, you detected antibody HCV. And to confirm diagnosis, you must detect HCV RNA, and you administer biochemical test and HCV RNA. You detected low HCV RNA and normal biochemical test or moderate increase. It is latent phase of a disease, but patient has chronic HCV infection, no hepatitis. We don't know we're developing clinical picture. And after 20 years, 10 years, virus reactivated, we're developing cirrhosis, when developing hepatocellular carcinoma, you know, disturbs function of the B lymphocyte, and another diseases. It is phase of reactivation. It is history of virus hepatitis C. And usually administer therapy before administer phase of reactivation. Because when developing phase of reactivation, patient has decompensation cirrhosis. Therapy will be difficult and severe. When developing carcinoma, operative measures, and atypical cells, PNU in the other organs. And before developing a reactivation phase, recommended administer antiviral therapy. And please look laboratory examination of viral hepatitis, what I said you know. Copy. And please remember, basic analysis to confirm diagnosis, PCR. In the exam, in the final lesson, will be tasked with viral hepatitis C, antibody HCV. You must write necessary administer PCR to confirm diagnosis. Copied? Continue. Please look extrahepatic manifestation of HCV infection. Lesion plainness, glomerulonephritis, mixed cryoglobulinemia, prevalent cryoglobulinemia, late cutaneous porphyria, cryoglobulinephritis, idiopathic thrombocytopenia, Sjogren, what is it? Is dryness of the skin and mucous membrane, B-cell lymphoma, autoimmune thyroiditis, rheumatoid arthritis, uveitis, and corneal ulcers. Doctors, if your patient has corneal ulcer, who examines this patient? Ophthalmology doctor, yes? If your patient has lesion plainness, who is examined? Dermatology doctor. But etiology of diseases, what is? It is HCV infection. And doctors, all specialties must be now clinical picture of many diseases connected with replication virus HCV, when necessary, when examined with patients with diseases, for example, syndrome Sjögren, glomerulonephritis, necessary examined to HCV infection. Copy?
Okay, copy.
Copy? Okay, continue. Outcomes of viral hepatitis C. This one. Clinical recovery, 20 to 25%. Chronic hepatitis, 1% when developing hyperactive immune response. Chronic HCV infection, no chronic hepatitis. Chronic HCV infection, what is it? Nephritis, autoimmune thyroiditis, it is HCV infection, 75 to 80%. And after 20 years, developing decompensation cirrhosis and hepatocellular carcinoma. Copy? Please copy. And doctors, when you must administer antiviral therapy, when patient has acute viral hepatitis, high level transaminase activation, say cytolysis, your therapy is not administered. You administer therapy when cytolysis decreased to 2-3 norms. For example, 40, 80 international unit per liter. When developing max cytolysis, virus replicated, this time you don't administer, against the background cytolysis, you don't administer antiviral therapy. And because acute viral hepatitis C outcome afterwards, chronization course. And before developing chronization course, recommended administer antiviral drugs. But doctors, in our country, this therapy, our patients must be himself by. No, it is the patient from our country. I don't know what in our countries, but recommended administer therapy when developing early recovery acute viral hepatitis. But when developing chronic HCV infection, recommended administer antiviral therapy when liver fibrosis, second stage and more. 0 and first stage, you may administer, you don't may administer. What want your patient? But when fibrosis 2 bowels, necessary administer therapy. Etiotrophic antiviral therapy. Inhibitor of NS5 proteins. absent signs, first time, what is your exam? PCR and fibrosis. And why necessary now? Maybe PCR 10/3 power, but in the dynamic results, usually course of antiviral therapy lasting 3 months. And after 3 months, effectiveness 0 load of RNA RCD. And please look, evolution of the therapy. Who had me administered interferon? When administered interferon, 1991 year administered interferon, but interferon have many adverse events, And 1998 year, administered combination interferons plus ribavirin, and the effectiveness only 30%. When 2001 year, administered prolonged interferons, 1 injection in the week, and combination with ribavirin. This effectiveness 50%, 56%. And only 2015 year administered without interferon therapy. It is a direct antiviral therapy, inhibitor of non-structural proteins. It is, for example, combination sofosbuvir plus declatasphere, or in our name, vilpanam. This combination drugs. And every year, PNU and U drugs.
Which is the patient when he has hepatitis C transmission level?
Transmission level connected with cytolysis. Maybe moderate, maybe mild. To control effectiveness, it is load HCV RNA and decrease fibrosis. Fibrosis second, and after therapy, 1 pulse, and maybe normalization. And our aim, stop replication virus. When virus replication, stop irrigation, stop affected hepatocyte, and increase fibrosis, and maybe decrease fibrosis. But our aim, stop replication and load HCV RNA 0 pulse. No, you administer during 3 months. During only 3 months. Course of the therapy now, modern course, 3 months. And please remember, interferon now don't administer. Interferon have many adverse events. Appear, for example, drop leukocytes, developing psychosis, and drop thrombocytes. If drop thrombocytes, what is it? Bleeding. And when drop leukocyte activated secondary bacterial flora. And now, effective drug, absent adverse events, it is without interferon therapy. Direct antiviral drugs against non-structural proteins. Do you understand me? Okay, let's have a rest, 15 minutes to coffee break, and after 15 minutes, I wait on you.
Okay.
Goodbye, doctors. So it is students online, 15 minutes. E. Doctors from all viral hepatitis is zooantropanotic disease. What's mean? Where source of infection, man and animals. Usually all viral hepatitis you discuss A, B, D, C. It is antropanotic disease where source of infection only human. But viral hepatitis is zooantropanotic disease with a fecal oral transmission mechanism of a pathogen prone to epidemic spread, characterized by liver damage with the development of acute hepatitis and jaundice, which is especially severe in women in the second half of pregnancy. Doctors, it is early, younger viral hepatitis than viral hepatitis. And first name of viral hepatitis E was viral hepatitis, no A, no B, etiology, fecal oral mechanism. And history of viral hepatitis E connected with Russia Federation, because scientist Balayan, 1983, detected this virus from soldiers. Last century, 1980, our country had a military war in Afghanistan. Our soldiers stay in Afghanistan. And our infected infectious diseases, don't only viral hepatitis and shigellosis and typhoid fever, and registered high percent lethal cases from infectious diseases via military. And our soldiers had severe post-viral hepatitis with hemorrhagic syndrome. And first time, doctors think it is severe post-viral hepatitis A. But from feces with soldiers detected another virus, and this name, next letter of alphabet, it is A, B, C, D, E. But first information in the world registered 30 years ago in India. Please look, 1955, 1956. Registered 29,000 people with viral hepatitis, unknown etiology. This usually prevalent men, and men infected result of drinking contaminated water with untreated water. And the documented outbreak, but when detected virus hepatitis E, present system with samples keep in bank of samples and examined it, and detected virus hepatitis E. And history of this disease connected with not only historical first focus of disease in India, next focus in Afghanistan. And usually it is disease characterized to endemic countries. What is countries where bad canalization system and good temperature to virus hepatitis A, tropic, subtropical countries. But it is a situation registered, and usually before 2015 year, it is usually disease characterized to endemic countries of East Asia and prevalent in India and Afghanistan. And with post-Soviet republics, it is Uzbekistan and Turkmenia. But now another situation, our century migration and focuses of disease registered in Europe, in Switzerland and in England. Usually in these countries registered only single cases connected with travel to endemic regions. For example, in our country, every year registered before COVID-19 situation, 1-2 patients usually from India, and our humans from our country or Indian patients. But now situation in our registered in the world when 2015 year in the England and Wales hospitalized 848 patients with viral hepatitis E. These humans didn't travel to endemic regions. This infected result at unboiling meat, pork meat. And what is actuality of viral hepatitis E? According to World Health Organization, estimates 2 million cases of hepatitis E virus infection occur annually in the world every year, and which causes 3.3 million symptomatic cases of hepatitis E. Again, after hepatitis E, don't develop it lifelong post-infection immunity, and human may be repeat infected. Antibodies against virus hepatitis E persisted maximum 3-5 years, and after with human may be repeat infected virus hepatitis E. And hepatitis E now, you understand, is done endemic, because focuses in the Europe registered too. And doctors, before 2015 year, in the world was information, usually this is characterized good prognostic disease without chronization cause, and only severe cause characterized to pregnant women, because virus passed from placenta, affected newborns, and characterized hemorrhagic syndrome to pregnant women. Why? Because pregnancy connected with immunosuppression and decreased immune response and developing severe cause of the disease. It is nature immunosuppression because necessary to keep newborn. But in our situation, now registered chronization cause of hepatitis E virus infection. And please look etiology of disease. Virus belongs to the herpesvirus genus. The virus is round-shaped diameter, 27 to 34 nanometer, no envelope. And this virus genome, RNA, characterized as common structure with RNA of rubella. And in this family virus, only one virus hepatitis E detected. And hepatitis E virus genome is single-stranded RNA with a length of about 7.5 kilobytes. At least 8 genotypes identified. And 10 years ago, registered only 4 genotypes. Now, plus 4 genotypes detected. And now you have information about 8 genotypes, but you don't know how many genotypes will be detected in the next years. And please look virology of viral hepatitis A, family, Hepativiridae, genus Orthohepativirus, and please look 8 genotypes. And genotypes first and second infected only humans, but genotype third and fourth infected animals. And fecal-oral mechanisms, and two genotypes first and second don't characterize chronization cause and characterize high mortality in pregnancy, 25% pregnancy women infected by hepatitis E, the result will be lethal. And genotypes third and fourth, zoonotic infection in humans, high-income countries, and genotype 4 registered in the China prevalently, and genotype 3 in the South America. Genotype 5 and 6 have only been reported in the wild boar, but genotype 7 detected from humans who like drinking milk of camel and camel meat. And this genotype identified in camels. It is characterized to Arabian countries, the usual culture of Arabian countries, and Kazakhstan, Republic Kazakhstan, like camel meal, Mongolia too, yes, Mongolia. And information about genotype 8 now absent, but detected. What will be, you don't know, necessary study. And doctors, please look where registered all genotypes. Geographical region of genotype. First, it is affected only human, mostly Asia and Africa. And genotype second, Africa and Mexico. Genotype third registered in the worldwide. And fourth genotype, China and Southeast Asia. It is, and please look, third and fourth genotype infected don't only human and infected and rabbit and pigs, monkeys and elks. And it is information about phylogenetic relationship of virus hepatitis E and nature reservoir of hepatitis E virus infection in animals and birds too, domestic birds infected virus hepatitis E. And doctors in the England, 800 humans infected results at pox from pigs farm of the England. Don't import it from another countries. And etiology of virus hepatitis E. Virus is hepatotropic, and hepatitis E virus is well safe at temperature below -20 degrees by centigrade for years, but is completely destroyed by rapid defrosting. You know, virus hepatitis A usually resistant to temperature -20, but don't destroy and continue pathogenicity after destroy. And the virus is sensitive to the effects of chlorine and iodine-containing disinfectants. And epidemiology. You know, if fecal oral mechanism and the source of infection are patients with acute form of virus hepatitis E. The susceptibility of hepatitis E virus is universal, but the disease is most often recorded in the age group of 15 to 29 years. Hepatitis E virus is more common in the form of epidemics and outbreaks. Sporadic incidence is also described. Reinfections and illness of hepatitis E virus are possible because antibodies persisted only short period, 3-5 years. And mechanism, fecal oral transmission, usually epidemic of disease connected with waterway, foodway, it is focus of disease, and single cases, it is context household. And you understand it is common situation as virus hepatitis A. If you drink boiling water, you don't may infected virus hepatitis A and E. And if you wash fruits and vegetables, you don't may infect it. And boiling this, for example, vegetables. And wash hands, you don't infect it from contact household waste. Hepatitis E virus can be transmitted by to the fetus placental in the third trimester of pregnancy. You know, virus A don't pass from placenta, but virus E pass from placenta. And extremely rare, parental route during transfusion from donors with asymptomatic viremia. Why? Now, from intestine, virus must go to the liver from blood. And this time, short time, will be viremia. When it is early stage of incubation period, and patient condition good, and this time this patient is donor, human is donor, it may be source of infection through hemotransfusion and realized from hemotransfusion. And pathogenesis, doctors, virus himself affected hepatocyte. Virus has direct cytopathic effect. Please look. Short-term viremia, virus replicated in hepatocytes. Hepatitis E virus has a direct cytopathic effect on liver cells, causing necrosis of individual hepatocytes. Hepatitis E virus excreted through the bile duct into the intestine. You know, it is common mechanism, way of virus and virus hepatitis A. From bile virus go to the small intestine and go out with feces to environment. And this time, human is source of infection. It is end of incubation period and height period of a disease. But when developing severe cause, you understand, virus himself affected hepatocytes and affected deeper structure of hepatocytes and developing hemorrhagic syndrome when developing severe cause of a disease. And please look, why developing severe cause of hepatitis E virus? Massive hepatocyte necrosis, total hepatocytes affected, plasma hemostatic factor deficiency, and developing thrombohemorrhagic syndrome, and hemolysis leading to acute renal failure, disturbs function of the kidney. Извините, ошибочно нажала, ошибочно, извините. Спасибо, извините. COVID? And continue. Clinical classification. Ecteric or ecteric form, it's common for all viral hepatitis and subclinical. And severity, it is common for all viral hepatitis, mild, moderate, and severe. Severity connected with complications with intoxication syndrome. And clinical picture, doctors. The incubation period lasts from 3 to 8 weeks. Pre-ecteric period from 1 to 10 days. Pre-ecteric period lasting to 14 weeks. And after developing convalescence period, convalescence period lasted 1 to 2 months. It is connected with individual characteristic each patient, individual characteristics. And doctors, clinical picture common for all viral hepatitis. And intoxication syndrome, it is pre-ecteric period was as dyspeptic variant, asthenogenic variant. You understand that don't developing arthralgia and don't developing rash. And after developing jaundice. But severe cause of characterized to pregnant women. And severe cause and fulminant hepatitis develop in 10% of pregnant women in the first half of pregnancy. But on the third trimester, severe cause increase in 20 to 40% of pregnant women in the third trimester. In the parturient woman during the first week after childbirth. And complications develop. What is result of virus pass from placenta, developing fetus little cases, but complicated acute liver failure, thrombohemorrhagic syndrome, massive uterine bleeding, gastrointestinal and other bleeding, and hemoglobinuria followed by renal failure and hepatic renal failure, severe cause of the woman. And it is complications prevalent in the third trimester of the pregnancy. Okay? Okay, I will. And doctors, what is the complications of newborn? Intrauterine fetal death, return birth, miscarriages, and childbirth in patients with hepatitis E virus are accompanied by large bleeding and high frequency of newborn death. Mortality of up 10 to 13% among pregnant women with hepatitis E virus. Mortality up to 20 to 40% among pregnant women in the third trimester of pregnancy. And doctors, usually hepatitis E virus infected pregnancy women when 50% of newborns after first days of during the first month of life die. If don't registered fetal case in uteri, and after first month, 50% died. And it is focuses of disease with pregnant women registered in Uzbekistan and Turkmenia, characterized severe course of the disease. COVID. And doctor, scheme of the disease, laboratory diagnostic, incubation period lasting from 15 to 60 days. And first time in the blood appear viremia, and after you detected virus in the feces, end of incubation period. When appear clinical picture, in the biochemical test, high level transaminase activation, appear clinical signs of intoxication syndrome, and first days of the disease, you detected antibody hepatitis E virus immunoglobulin M, and together appear immunoglobulin G. But after 9-10 weeks, transaminase activation decrease, and together developing recovery, and together decrease level antibody immunoglobulin class M against virus hepatitis E. But antibody immunoglobulin G persists, but persists only 3-5 years, and after disappear. Continue. And doctors, laboratory diagnosis of hepatitis E virus infection and current infection acute. you detected hepatitis E virus RNA plus antibody, hepatitis E virus immunoglobulin M. Together, you may detect immunoglobulin G, and you may detect hepatitis E virus antigen. And when developing chronic cause, you detected hepatitis E virus more 3 months after onset of the disease, and you detected hepatitis E virus antigen. When developing recovery, post-infection, only antibodies plus G. Да. Да, Сергей Викторович. Да. Ага. Ага. Ну, конечно, конечно. Спасибо вам огромное. Тогда я скажу, пускай идут в приемные и говорят, что, ну, как бы, да, вот фамилию называют и все. Спасибо. Ваше 4-е инфекционное отделение, да? 5-е. Это просто нам скажет, что договорились было с 5-м инфекционным отделением, если это что. Все. Хорошо. Спасибо вам большое. Всего доброго. Доктор Солин. And it's common principle when developing post-infection immunity, absent RNA, absent antigens, only antibodies plus G. Antibody, hepatitis E virus, immunoglobulin G. And this, it is what is laboratory test necessary to administer. Doctors, in our clinic, for example, you examined only PCR because don't necessarily examine antibodies. Why? Because how many analyses must be? 90. But in our clinic, in the year, registered 1 or 2 patients. And PCR. But in endemic countries, yes, necessary ELISA, don't necessarily administer PCR because PCR are rich than ELISA. Last slide, please. Chronic, after 3 months. Stop clinical picture, absent intoxication syndrome, decreased jaundice, but you detected hepatitis E virus RNA, more 3 months. During 3 months, it may be because disease lasted 2 months, 3 months. But if more 3 months you detected genetic material RNA, it is chronization cause of the disease. Okay, and doctors' outcomes, repeated, total recovery and post-necrotic cirrhosis, you now developing cirrhosis, necrosis of the liver cells, result total affected virus himself affected hepatocytes, and developing post-necrotic cirrhosis, fetal outcome, no more 1%, it is not connected with pregnant women, only men and unpregnant women, 1% developing acute hepatic encephalopathy, and to pregnant women, 25% developing fatal outcome. And new information after 2015 year, it is chronic HIV infection, no hepatitis, because affected nervous system, first time, hematological and nervous system, and chronic HIV infection. And please look, are you copied? Extrahepatic manifestation. What's mean extrahepatic manifestations? Please look. Affected meningitis, affected thyroiditis, neurotic amyotrophy, cryoglobulinemia, myocarditis, glomerulonephritis, pancreatitis, lymphoma, thrombocytopenia, arthralgia, myalgia, Guillain-Barré syndrome, and doctors affected neurological cells, hepatocytes, kidney cells, and Langerhans cells. Langerhans cells, what is affected? Skin. And prevalent affected nervous system, neurological manifestations. Copy it. Copy it. Take photo. Okay. And doctors, first place, it is neurological. In the Switzerland registered humans who infected virus hepatitis E had after neurological diseases. What is neurologic amyotrophy, Guillain-Barré syndrome, Bell's palsy, myositis, mononeuritis multiplex, meningoencephalitis. Please look. It is clinical diseases connected with third genotype of hepatitis C virus. In Europe, registered more 150 cases of neurological injury, and 90% of these patients don't immunocompromise. It is immunocompetent persons. And second place, renal diseases, membrane proliferative glomerulonephritis and membranous nephritis, and immunoglobulin A nephropathy. It is renal diseases connected with third genotype of virus hepatitis E. Renal function improves and proteinuria levels decrease following hepatitis E virus clearance. And third place, hematological disease. What is thrombocytopenia, monoclonal immunoglobulin, cryoglobulinemia, aplastic anemia, and hemolytic anemia, and reported in 25% of cases of acute hepatitis E virus in the United Kingdom study. And occurs mainly hematological diseases associated with renal disease. Mild thrombocytopenia is common and occasionally severe. And another clinical manifestations connected with first genotype and in the world registered, not only in the Switzerland and England and all countries, and it is arthritis, acute pancreatitis, myocarditis, and autoimmune thyroiditis. But it is autoimmune diseases, thyroiditis, arthritis, myocarditis. It is disturbed immune response. And doctors, it is new information. Please look. 2018 year General Pathology informated us about chronization. But you don't know what is in our organs may be affected. And prevention, doctors. Now in the China, scientists synthesized vaccine against virus hepatitis C. China's first hepatitis C vaccine launched in 2012 here, but in our country, this vaccine is not registered because single cases don't necessary for us buy this vaccine. It's not actual. But in endemic regions, recommended administer a vaccination against virus hepatitis E. Why? If before 2018 year, you may be vaccinated, you may be not vaccinated, because it is your choice. But now, you take another information, developing chronization, chronic disease of neurological system, it is immunization and necessary vaccination who live in endemic regions. And common prevention, it is anti-epidemic and sanitary measures. It is epidemiological service must be control of central water and control disturbance of centralization, prevent disturbance of canalization of water. It is full information about viral hepatitis E. I have questions? No. But then virus hepatitis E, then another viruses don't register in the worldwide. Registered, but it is focused on total infect of population. Okay, and doctors, principal therapy. From pathogenesis viral hepatitis A, 100% developing recovery. Human's immune response, himself, virus eliminated. Virus hepatitis B, immune system, 95% eliminated, virus developed, recovered, sanated virus. Yes, and virus hepatitis C, it's another situation with connected with 5% chronization cost, and virus hepatitis E, how many percent developing chronization, you don't know, this new information, but developing recovery. Yes? And when patient has acute phase of the disease, when patient has marked intoxication syndrome and jaundice, immune system himself, virus eliminated. And our aim only help to immune system. You don't administer antitropic drugs. Antiviral drugs, you don't administer. You must administer only pathogenetic therapy because T cells, B cells himself eliminated the virus. And patient has what is pathogenetic syndrome, intoxication, connected with disturbed liver cells. You must administer pathogenetic therapy. It is disintoxication. What means you administer? Intravenously drop colloid and crystalloid solution. When you administer 1 part colloids and 3 or 4 part crystalloids. Why? Intoxication syndrome, you recommend only colloids, but what do you do colloids? Affected kidney, disturbs filtration function of the kidney, and recommended administer only 1 part colloids and 3 or 4 part crystalloids. And if patient may drinking, for example, absent vomiting, absent nausea, recommended drinking water. What is water? It is juice. It is a tea with sugar. Because necessary sugar, it is a structure of glycogens. And you together administer drugs with function asthmatic diarrhea. Lactulose dufalac, because necessary every time evacuated large intestine, where present ammonial compounds and gram-negative bacteria. And cleansing enzymes with low resorption antibiotics. Why? Against gram-negative bacteria to prevention synthesis and the toxin. The toxin and the toxin activated synthesis cytokines and correction of water electrolyte imbalance. It is detoxification pathogenetic therapy and symptomatic therapy. Patient has jaundice. You administer spasmolytics and increase size of bile ducts and bile pass from these bile ducts. And together, when developing severe cause, for example, complication cholestasis, you must administer ursodeoxycholic acid preparation and cholestyramine. But ursodeoxycholic acid you administer when transaminase activation decreased to 3 norm, 2-3 norm. If you administer against background high level ILT and IST, will be developing a relapse, enzyme relapse. And cholestasis therapy, it is antibiotics, cholestyramine, spasmolytics. Doctors, when transaminase activation high, you don't administer ursodeoxycholic acid drugs because developing enzyme relapse. And when developing encephalopathy, you must administer severe cost hemostatic therapy. You must every time monitoring prothrombin index and you must administer branched amino acid solutions to concurrent with aromatic amino acids, and prevention of possible gastrointestinal bleeding. And doctors, when you're talking about fulminant cause, you understand what is immune response when developing fulminant cause. What is character immune response? Adequate, hyperactive, or poor? Fulminant cause of a disease. What do you do immune response? Hyperactive, because total liver cells affected, T cells and B lymphocytes affected. And when developing hyperactive immune response, necessary decrease this response. What do? Recommended administer immunosuppression. But you administer immunosuppression and activated replication virus. And recommended when developing severe cause of a disease, administer immunosuppression, glucocorticosteroids, plus antiviral drugs. When you administer antiviral drugs, co-infection, superinfection, delta, severe cause of viral hepatitis B, when developing complication encephalopathy, you administer antiviral drugs. But to administer antiviral drugs, you must confirm high load replication virus hepatitis B, 1 million or 100,000 thousand you administer antitropic drug, because necessary decrease load of HBV DNA. And if load HBV DNA low, don't irritate immune response. And together you administer immunosuppression. Have you questions? Do you understand? Okay. And doctors, I must take photo of online students. But students, how many? Only 30. Where another doctors? And our plan, doctors, you have time to lunch 30 minutes. Doctors, are you listening to me? Online doctors?
Yes.
30 minutes lunch, and after lunch will be practical lesson. Offline doctors may be exam patient. Online doctors only discuss history of disease and tasks. But Monday, 8:30, you return meeting in this Zoom link. Will be discussed theme malaria. Online students, are you listening me?
Yes.
Please, from this link Zoom, come to me Monday. Okay?
Okay.
All right.
Goodbye.